tell me and didn't think it was a big deal. So I'm here to advocate for people on the prevention side.
Mila, can you jump in for us?
Yeah, so I started writing about diabetes after I was diagnosed with type 2 in 2016. And my motivation was really just that I went to a lot of doctor's appointments that left me really confused and I felt clueless. But I also was rebelling a little bit because I had some interactions where I was told you can't eat the foods that you love culturally and you're going to have to kind of like change your life, only eat kale, and that's how you're going to manage your blood sugar. And those interactions were incredibly frustrating because I wanted to live a good life with diabetes, but also not give up every single thing that I knew in my life. So I started developing recipes that were easy and accessible and affordable for people, but that used ingredients that they recognize and still kind of helped to balance blood sugar. So that's how I got my start in the community.
Thank you for that. Throwing it over to Quisha.
Good morning and good afternoon, wherever you may be today. Again, my name is Quisha Umemba. I got involved with diversity and diabetes probably after speaking at the 2019 American Association of Diabetes Educators Conference. So preparing to speak on how we engage Blacks and African Americans in national diabetes prevention programming, I was preparing for the talk and researched the rates of Black or African American certified diabetes educators. And at that time, and using 2017 stats, we were represented by less than 5%. I think it was 4.8%. Asians were even less than that. And so it really stood out for me because we know the communities of color account for the highest rates of people that have diabetes. And so I really started taking a look at the lack of diversity and representation when it came to healthcare providers in general, specifically diabetes educators and people that work with patients living with diabetes and of color. And since March, about 8 months ago, when I met Casey Creel, who is my co-founder of Diversity and Diabetes, and we put on the People of Color Living with Diabetes Summit, I've just been more invested and more passionate about doing this work, noticing so many gaps in this area.
Awesome. And last but not least, Kyle, can you tell us about yourself?
Sure. Kyle Banks. I'm an actor and singer. Most of my work has been in theater. I was diagnosed with type 1 diabetes in 2015. And because of my work in theater, I've always been involved with Children's Hospital. We do a lot of outreach with visiting kids who are ill, and we do a lot of outreach in that area. So after my diagnosis, I reached out to Children's Hospital just to see how kids were going about managing their having type 1 diabetes, because I was having such a rough go at it, especially the first year after my diagnosis. And that's when I just really learned how grave the situation is as far as and being able to access the technology available and properly manage glucose levels, and so that led to me founding Kyla Cares, and we provide transfer insulin pumps and continuous glucose monitors for kids and young adults living with type 1 diabetes.
Thank you. And we're going to talk more about Kyla Cares later on and journey towards that. But before we delve into the meat of our conversation, I just wanted to go over a few things. So of course, we're going to be talking about our survey learnings and our personal experiences as by POC diabetes advocates or providers. Our goal is to gain a better understanding of how that shaped our work and our advocacy. Our hope is that with this conversation today, we leave those in attendance with a better idea of how to raise the visibility of people of color within the diabetes space. So that is why we are here. Speaking of visibility, one reoccurring theme within our survey data and videos was the desire for representation. One Black participant with type 1 expressed their desire to be included in the narrative of care for individuals who have diabetes. Another stated, "We don't exist really. We're muted way too much, and when we are allowed to speak and talk, it has to be about color and equity and inequalities instead of normal diabetes stuff." So Quisha, as the co-founder of Diversity in Diabetes, can you share why the topic of representation is worth pursuing within the diabetes space, and what happens when we ignore it?
Yes, thank you. So people of color living with diabetes experience a 60% higher chance of being diagnosed with diabetes than non-Hispanic white Americans. We are the worst at everything across the board. Okay, so it's good to come in first, but not always good to come in first when it comes to chronic conditions like diabetes. We're twice as likely as non-Hispanic whites to pass away. We're more likely to be readmitted to the hospital or admitted in general to diabetes. We're more likely to have higher rates of diabetes complications. So I'm talking about things like kidney disease. I'm talking about lower extremity amputation. And we're largely underrepresented in clinical trials. So when you ask me what's at stake, there's so many things at stake, right? We have entire communities that are at stake at higher morbidity and mortality rates. We have, of course, the individual that's at stake. We have generations that are at stake because we know that diabetes has a genetic component to it, right? But then from a healthcare provider standpoint, we have our entire healthcare system that's at stake. We've not got the best healthcare in the world, and we should. We're the United States of America, for goodness sake. And so, there are so many different things at stake if we don't take a proactive approach as opposed to this reactive approach that we have. And we really have to admit that at the end of the day, we're all affected in some way or another by not getting a handle on this.
So right, in terms of talking about entire communities at stake, and the higher incidence of morbidity and mortality rates, as well as the role of the healthcare system. Mila, as a chef and food blogger and author with visibility both within the diabetes space and beyond the diabetes community, what advice do you have seeking to address representation on their platforms and in their marketing strategies?
I think that it's super important to listen to patient voices, and we all know that. We know that patients should be represented at like the very baseline of anything that a diabetes company does. But I think it's also really important for those same companies and those same institutions to really take the feedback seriously, and especially when it comes from people of color. And there have been so many times where I feel like I've been asked to be in a room because I was like the token Black person that could give like the token Black experience. And like, as we know, like Black people are not a monolith. And so asking me to like provide all of the insight that I have and saying that that equates to everyone else's experiences is just unfair. But I think sometimes when we're offered a seat at that table and a seat in that room, we're there and it's a token thing. It's not necessarily because our feedback was wanted. It's more of a show. And so I think it's really important for companies to recognize that if you're going to ask us to be in that room and you're going to ask us to speak up and put our voices on the line and be a part of that feedback, it's important to listen to that feedback. And also, so don't ask us to be there just to be there, but ask us for our feedback because you really want to make a cultural change and you really want to shift things to make sure that people of color are accounted for in those conversations.
Yeah, and that brings us to the idea of being genuine and the importance of being genuine. And you suggested that one way to do that is to actually and incorporate the feedback of those people of color who are being invited to the table, and not just focus on the tokenism of their presence. So thank you for sharing that. When considering access to diabetes care and technology, one major point of concern for the respondents in our survey was cost. Kyle, you talked a little bit earlier about how you came to founding Kyle Our Cares Foundation, but I wanted to turn it back to you and allow you to talk a little bit more broadly about some of the statistics around technology usage for BIPOC and how that relates to the work that your organization is doing.
Thank you. There's been a number of studies that dive into like racial and ethnic disparities in management. Also, like focus on like the multiple factors that go into why a lot of these statistics are the way they are. I think in terms of like access to the technology, people of color like are infrequently use insulin pumps and CGMs. I think the numbers are around 61% for European people versus 26% for African Americans, and that number is also low for people of Hispanic descent. And then we also infrequently perform self-glucose testing via fingerprint pricks, and we're also not using the CGMs, and this leads to like prolonged elevated glucose levels, which also results in like greater number of complications. And some of those contributing factors include like socioeconomic status, less contact with diabetes care providers, which is sort of, because of COVID, telemedicine is sort of helping that out a little bit. So hopefully that will begin to improve as telemedicine grows. But we also have like difficulty relating to healthcare staff because of cultural differences. So it just leads to us not being able to utilize this technology and make the optimal and receive the optimal benefits that these types of technologies provide. So the reason I founded Kyla Cares was to sort of reduce some of the financial barriers that people face with accessing the technology. But that does not answer like some of the other problems that we see in terms of accessing the technology, because then there's information on like how do you really incorporate this technology into your management of type 1 diabetes, and learning how to really efficiently use it, and all of like the bells and whistles that really give you the best results that lead to the best results when utilizing the technology.
Yeah, so you talked about the underutilization of technology and the lower number of testing rates because of a variety of reasons, right? Economic, cultural differences, lower touch points with healthcare providers, lack of access to adequate information. And so with that, I want to turn over to Joyce, because I know that as a senior community health worker, you've heard from your clients and patients some of their concerns around the barriers and challenges to access in diabetes care and supplies. And so I'm wondering if you could elaborate on some of these challenges that Kyle just brought up, as well as discuss some of the resources that you've utilized to help your patients overcome some of these challenges.
Sure, thanks, Kyle. Yeah, as a community health worker, I'm actually the person with the patient in the circle of care. So I am the bridge between the providers and the patient. And some of the patients that I have worked with actually they don't really know how to use a glucose monitor, which is really sad. They don't know what the levels are for fasting and post-meal blood glucose levels. And I've talked to providers about this, and they said, yes, patient on that. So the feedback loop on teach back is not happening. I don't know what it's going to take to do that, but I think being a community health worker is really going to help in that area, because we have some more time to provide to patients. And I think this is the commodity that's really at, I would say, the least amount that's at least available to healthcare providers is time. And so as a community health worker, I am there to really listen to them and be patient. You know, throwing out these numbers, it doesn't mean that they're going to know what that means like immediately. It has to be put into perspective. So I've been helping my patients with that. Also, some of the resources in terms of cost with test strips, you know, they can go between 15 cents to $1.50 per strip. And depending on where some of the patients are in their diabetes journey, they have to test either once to 7 times per day. And so these costs can really add up for some of the BIPOC community members, whereby, you know, some of these packs of diabetes strips comes in 100. So you can't just, hey, I'm just going to take like, you know, I just need, I don't know, 30. No, you're going to have to get like the actual pack, and that could be $25 at the very least if you qualify for a program, like for One Touch, let's say, for an example. And that's $25 for 100 strips. So it can last you between 2 weeks to 3.5 months. So when we do the math, and you're looking at social determinants of health for some of these folks, where they have to have transportation assistance, financial assistance, food assistance, a lack of education because of where the community where they're living, it really starts to show you how close health outcomes is to education and some of these barriers that they're experiencing.
So thank you for touching on the connection between the social determinants of health and lack of education and what that means in terms of the prevalence of some of these barriers that those within the BIPOC community face. One thing that you brought up was your position as a community health worker and the advantage that you have in comparison to other healthcare providers, and that you get to spend more time with the patient, you get to listen to them, and actually respond to what they're sharing with you. And so that brings me to my next question, which touches on one of the reoccurring themes from our data, which was the value of and desire for empathetic doctors and healthcare providers. And so going back to you, Joyce, can you speak the value of culturally competent care to the community that you serve? Maybe you can even tell us what that means and describe what exactly that looks like for you in Dallas.
Sure. So for cultural competency, it really is, we just have to take personal ownership of who we are as people first. And this actually goes hand in hand with how to be an ally during these times of Black Lives Matter movement that we're in. And as COVID-19 has just exploded and showed these health disparities, we really can take this as an opportunity to learn ourselves first and own that. And when we meet the patient, just be upfront with it. Say, hey, listen, look, this is something that's new to me. I know how to treat you. I know, what's on your chart, but tell me a little bit more about yourself. I do my best to connect what I learned from my patients to the actual providers and say, hey, listen, these are some of their barriers. Just be careful how you approach and how you say things to some of our patients. Speak a little slower, but don't speak so much that you're talking to them like a child. Know that we have the literacy level of our patients are 7th to 8th grade level. That's nationally. That's our literacy level, you guys. And this all goes hand in hand with digital literacy. Digital divide is widening. With this innovation summit, I'm learning so much, but it's getting more and more disparate because we're not helping people really understand or tackle digital literacy here. So going back to this, I really feel that, owning, like I said, your own experiences and listening to the patient and taking it one step at a time. Try not to overwhelm the patient, and also say, hey, listen, it's okay if you don't understand it the first time. We are here for you. As a provider, I'm here for more like really more of the clinical side, but I have Joyce, or I have so-and-so who's a community health worker, social worker, nurse, and they can spend just a little bit more time with you just to go over some of these details that you think might be more helpful to you to understand, because we're here to really help you. We're here on your team. And I have to say, whenever I meet a patient, they still can't tell me what diabetes is. And that just drives me absolutely crazy.
Thank you for sharing that. So you talked about the importance of knowing ourselves and taking ownership of where we're coming from and what we bring to the table and our own gaps in knowledge, and being very transparent about that with our patients, and letting them know that we are approaching the conversation from a place of learning. Based on that, I want to turn it to Quisha, who also represents for the providers, and ask, what are some ways that providers can be more intentional about delivering compassionate and supportive care?
Thanks, Ariel, for that question. I love that Joyce started out with, we have to start with ourselves. I do agree that healthcare providers do need to start with themselves. And first things first, they really need to acknowledge that provider bias exists, right? I like to say having biases makes us human. It doesn't make us bad people. It's when we act on those biases that it adversely affects patient care. So we really need to acknowledge that it exists so we can identify them, and then we can take concerted efforts to ensure that what we think or how we feel about a particular individual or a community does not influence the way that we actually provide care for them. Secondly, I really think, especially when we're talking about diversity and inclusion efforts, we have to be intentional. And so when I talk to providers, I tell them all the time, be intentional about providing the same quality of care to all of your patients, regardless of their race and ethnicity. Now, I'm not saying don't take into account culture, social environment, past experiences, finances, literacy level, just like Joyce said. But when we look at research study, I don't know about you, but when I'm prescribed a medication and I read up on it, it doesn't say white people take this and Black people are going to take this amount. And so we really have to be intentional about making sure that all of our patients get the same quality of care. And then, as Joyce said, we've got to be providers, educators have got to be better allies. We know what an ally is, right? It's uniting yourself with someone for a shared or common interest, right? It's usually mutually beneficial. It is an alliance. And in order for you to do that, you've got to start with listening. You've got to be empathetic. You've got to understand, or try to understand. You've got to try to put yourself in their shoes. You've got to try a non-judgmental approach. All of these things you have to start doing, and it starts with the individual first before we can, go any further from there.
So I love what you brought up in terms of the importance of being intentional, and providing the same quality of care to all patients, regardless of background, as well as the importance of educators actually being allies, and showing that by doing a better job at listening and trying to understand. One thing that you discussed that is a perfect segue to our next question, is the importance of acknowledging that provider bias does exist, and realizing that there's nothing unnatural about that, but that the issue arises when we actually act on those biases, right? And those biases actually impact patient care. And so during this survey, several respondents attested to how stigma has impacted their diabetes care. Karina stated, sorry, I'm hearing some weird feedback. Karina stated, speaking with an accent is not an indication of intelligence or education or acceptance of Western medicine. Don't let assumptions and stereotypes get in your way. Kylie shared, we should never judge someone based on the color of their skin to determine what type of diabetes they have. Diabetes does not discriminate. So Mila You recently shared your misdiagnosis story. Can you talk a little bit more about how stigma played a role here and the impact that that had on your health and well-being?
Definitely. My favorite. I'm getting a little bit of feedback. You guys hear it?
Yeah, perhaps we could all mute our mic.
Better? Okay, much better. Yeah, sounds good. Cool. So yeah, I, as Ariel mentioned, was misdiagnosed with type 2. And I just recently found that out about 2 months ago. I definitely think stigma played a role in my misdiagnosis. And if you would have asked me this question like a couple months ago, I would have thought like, maybe not, it's a fluke. It happens to people. But when I really reflect on my misdiagnosis and I think about how I was treated when I was diagnosed with type 2, I went to my doctor with glaring issues and I was like, I am literally peeing every hour and I can't stop. I am so thirsty all the time. I've lost 30 pounds in about 8 weeks. That doesn't seem very normal to me, but I do have a family history of type 2. My mother and grandmother both have had gestational diabetes and then had type 2. And kind of gave my doctor that information. And I feel like he looked at me and he said, well, you're overweight. You have a family history of type 2. It's probably type 2. And so I was never tested. So I feel like he overlooked things like my age. I was in my mid-20s when I was diagnosed with type 2, which isn't completely unusual, but it's also not that normal. And some of the symptoms that I kept saying, like, these are things that I've been noticing. This is odd to me. We're kind of blown off as like, yeah, it's normal. You have type 2. Here are a few medications. Come back and see me in 3 months and we'll take your A1C, without any like information on how to move forward, what to do, or just how to make it better. And to me, that really signaled like a lack of listening and a lot of assumption, because like 4 years later down the line, I again had more symptoms. I was going back to the same place. I was seeing blood sugars in the 400s and 500s, despite like amping up exercise and like really watching what I ate, restricting carbs to like a level that I never even thought was possible. And it finally, like 3 doctors later, I was seeing a doctor who had a lot of humility, and she said, well, I can only take you so far. I feel like we've increased your medication to this level. I feel like we've increased your insulin intake to this level. You're exercising. I can clearly see you're putting in the effort, but your effort isn't matching. And I don't want to do more for you. I want to send you to somebody else who is going to be able to give you a better answer. And I wish that I had pushed a long time ago to kind of like get this answer of LADA. But I also felt discouraged. I felt like, okay, I'm bringing up these things that I think are kind of abnormal, and my doctor is saying that they're not that big of a deal. So like my doctor knows best, and that's fine, and that's where I'll go. And it wasn't until I went to someone who was like, something else is at play here, but I am not comfortable enough diagnosing you. Like, let's send you to a specialist and figure it out and then get more answers. And then we can work together again to make sure that we are getting you kind of like even keeled and on an even level. And the doctor who sent me to an endocrinologist was a woman of color. The endocrinologist was a man of color. And so I feel like when I sat down in that office and I said, here's my diagnosis story. I was diagnosed with type 2. Here's what happened. Here are all of these things. The endocrinologist said, like, I know exactly what's going on. We're going to test you to confirm it, but I think that you have LADA. And then he explained to me what it was. And then he told me what that meant for diabetes management. And so like I had these different experiences, I think, with doctors who kind of understood where I was coming from culturally and who pushed aside kind of like the outward appearance and I think the kind of like checkbox things that you say like, okay, this person has type 2 because they're this, and this. And I feel like because those things were pushed aside and they actually like sought more answers outside of that, I am having a better outcome. And now I have the diagnosis and the right diagnosis that I need to be able to manage properly but I don't think that my initial diagnosis had that level of, I think, discernment. Like, my doctor wasn't looking at necessarily what the deeper problem might have been. I think he was more looking to say, like, okay, here's where you are health-wise. I don't really have that much time to spend with you, but this is what I see without looking any deeper. And so, like, this is the diagnosis I'm going to hand you. And for me, I think that's a dangerous position for people to be in. And I think more people are misdiagnosed than you think. But I think sometimes those misdiagnoses come from that assumption without digging just a little deeper. I had lots of friends in the diabetes online community tell me before my doctors did that they thought that I had LADA, and they kept telling me to push and push and push until I got an answer. And I think if it wasn't for them, like, I would have never known. I probably would have just lived my life kind of going along until something happened. And I would have been okay with that. But people kept telling me, like, I think you need to have someone dig deeper for you because you're just getting seen at the surface level, and there's probably more to it than you think. But then I also think too, you know, getting tested to confirm your diagnosis is a simple blood test. And it was always presented to me as it's something really difficult. Your insurance might not cover it. And when I found out that, like, it was the same as getting my labs taken, it made me wonder, like, why didn't I ask this question before? Or why didn't my doctor just say, like, hey, with, like, the balance of symptoms that you're having, let's confirm this to just make sure, and not just, like, let's assume because you check these boxes.
Yeah, so you alluded to this a little bit as you talked about your misdiagnosis story. But what do you suggest for someone who might be experiencing pushback from their doctor? There was actually a question in our chat that says, could you please share tips on how people of color can become better advocates for themselves and push back against the resistance they might face and secure better care for themselves?
Yeah, I think just arming yourself with as much information as possible is the first step. So if you feel like something is wrong, keep listening to that gut feeling and understand why you feel like it's wrong, and understand how you can explain that to your healthcare team to get them to take you seriously. I unfortunately had to change doctors twice before I found somebody who would listen, 2 doctors who I love and who are awesome on my care team. And I recognize too that that is a level of privilege that not everyone has, because not everyone can just, like, switch doctors at the drop of a hat and go to someone new. But I think if you have the information that you feel like you need to explain where you're coming from, and you really take the time in your appointment to say, like, this is a priority for me and this is what I want to know, and, like, here's where I am and what I think I know, and I would love for you to help me fill in the gap. It's really important to be able to have those open conversations with your doctor. And if you feel like you can't, then you really have to seek out somebody who is going to be that support, whether it's a diabetes care and education specialist, or it's your doctor, or it's your endocrinologist. Like, finding the person who is going to listen is going to be your biggest tool to use in terms of managing your health. I think also I had a lot of support within my own family. So when I noticed that things were wrong, or when they noticed that things were wrong, it was kind of a flag to me to say, like, I think I need to ask this question, or I think I need to, like, get a different answer or hear something different based on, like, what I'm noticing and what other people are noticing. But then also the other thing, and the last thing I'll say about this, and I think you guys may have some great things to chime in with as well, but I think that it's really important to recognize that, like, you are the boss of your own health. So, like, nobody's going to ask these questions for you. Nobody's going to push as hard for you as you're going to push for yourself. And if you can, or you have yourself or some kind of support to be able to encourage you to, like, really walk in there and ask the questions that you need to ask, I think that's really important too, because at the end of the day, like, I think it sounds so harsh, but, like, you're responsible for yourself for the most part. And so the more that you can do, even though it's taxing and tiring and exhausting to be the person that's like constantly worried about your health, the more that you can do, the better outcomes I think you have as a patient.
If I can just chime in, I mean, you said everything that is basically on my patient advocacy list, Mila, but I also wanted to say, you know, we really have to empower our patients to be the CEOs of their life. And so I tell my patients all the time, you know, you can hire and fire at will. The same way that your provider can you know, fire you as a patient as well. And like you said, of course, everybody doesn't have that option, right, or that opportunity. But it is about making them, you know, arming them with that knowledge, making sure that they are an active participant. And like you said, finding that ally seems to be very helpful. So, you know, whether it's a community health worker or it's, you know, somebody in the family that can go and speak on their behalf. Maybe there's a nurse in the family. Trust me, I'm the token nurse in the family that everybody calls for everything. Maybe it's a nurse that you take to the appointments with you, it's your cousin or whoever, or maybe it's, you know, that RD or that nutritionist that you've really bonded with that can speak on your behalf. But you have to be a CEO of your life and of your health and hire and fire at will.
I like that, the idea of being the CEO of your health and your life, and being an active participant in your care. Something else that Mila talked about, besides the fact that the provider who did listen to her ultimately were people of color, but she also talked about the role humility played with one of her providers and how that provider ultimately recognized their own limitations and realized that they needed to refer her elsewhere. And so with that, I wanted to turn it over to Joyce. Can you talk about some ways that you've worked to ensure a stigma-free patient-provider experience?
Sure. A lot of this goes into really setting expectations from the get-go. And I think that this is the big miss in healthcare, is that you're assigned to a provider and they don't tell you, hey, like, this is a two-way street. I'm here to help you. And, you know, you also have to help yourself. So what I do with my patients is that, hey, okay, this is my role. This is what my scope is. And I said, if for any reason you don't feel well today, or you don't feel like you can communicate with me, it's okay. You just let me know and we can move on and I'll just reschedule you. Now, again, you know, my role is different from a provider, but I can listen to them and really identify, hey, like, they are not at a time and place of learning about their blood glucose monitor. And then I hear and I say, so what's really going on? You know, do you want to talk about it? And usually they do open up and they say, I'm just having a bad day. And then usually it goes into some mental health issue. So I go and try to provide them some social coping skills in more conversational tone and see what they've tried and what they haven't tried. Most of my patients that I'm helping reduce the stigma is really about trying to figure out what it is that's preventing them from wanting to do better for themselves in terms of their health. And it's usually, there's a lot of shame, there's fear. They don't want to say that, you know, I don't have enough money to eat. So these are the population, this is the population who I work with. And I understand that, and it's very traumatic. So I also try to be careful and, you know, just saying things that maybe a lot of people can take for granted. Oh, just go to the store and pick up some groceries. No, you can't assume that people could just go and pick up whatever healthy food, you know? So tell me more about the store that you go to, what's available there. So having more open-ended questions, I feel like can help reduce the stigma, because you're actually looking at the person from their own individual perspective, as opposed to, hey, here's the chart, here's the patient chart, and this is what I think where this patient is at. Or here's a social determinants of health wheel, and they're low on this, or like this is a high risk. still confirm, still ask those questions, and ask for permission to ask those questions. Don't just ask them to ask. So I think that helps with providing a stigma-free environment. And I have heard my providers kind of talk down to some of the patients. And the patients have come to me and told me about it. And again, this goes back to the self-empowerment. And I said, okay, so tell me exactly what happened. And I said, okay, well, would you be comfortable with me talking to them about this in a way where it's not a blaming scheme? And they usually say how you're going to say it. So I've explained to them, well, I'm just saying that you don't understand specific things and you need more time. And in the next patient visit, I can be there if you'd like. So that has happened in the past, where I have been invited by both patient and provider to be in the same room to help with the conversation. And I think that helps the providers kind of have some sort of cushion or comfort in that I am there. And I say, I am on your team too. And I also tell my patients, I am also in the provider team. So I am here, this neutral space, but I'm really here to help you get, become healthier. So hopefully that has helped with it, creating a stigma-free. And actually also wanted to add that I advocate for myself to get more resources on how to be an ally and how to be more culturally competent. And I think that anywhere where we work, play, eat, sleep, we need to ask for these and education so that we can help other people feel more comfortable to just speak about their own health and what they're going through so that they can get on to the next step so they can feel better.
I like that. So you talked about the importance of kind of normalizing this idea of the two-way street, where the patient is also giving the provider feedback, and it's just not one directional. You also talked about the importance of open-ended questions or motivational interviewing to really get a better idea around the source of some of the issues or concerns that some of your patients might be feeling, in order to prevent acting out on any stigma, as well as kind of leveraging your role as a community health worker or social worker as this neutral individual who is on both the side of the provider and the patient. So with that, I'm going to transition to diabetes education. Because I know that was a concern for a lot of our respondents in the survey. We had one individual, Danielle, who stated, I don't feel like POCs get the same treatment and options with technology and care. We have a long way to come in terms of getting the same options as everyone else. So I'm going to throw it to you, Kyle, as a proponent for and beneficiary of diabetes technology. What are some tools and strategies you use to ensure you've gotten the most out of your patient-provider relationship?
Thanks, Ariel. I know that I remember my first year after being diagnosed, and it was a total mess. I probably fell into the category of a lot of the horrible statistics we hear with regard to people of color and management of their diabetes. Oftentimes I would find myself sitting with my provider, having no idea why decisions was being made with regard to my care, or how those decisions would actually affect my treatment. And honestly, at the time, I was just so overwhelmed, and the intel was just too much to take in. But it wasn't until I really took the time to research what was going on with me, what was happening to me in my body, and why, that things began to turn around with me as far as management is concerned. And it was at that point that it really allowed me to be more vocal in the office with my caregivers, to ask questions, and it really allowed me to just gauge a better understanding of the care I was receiving, the decisions they were making, and I just became a bigger part of that whole process. And it really empowered me to just take control, like Joyce and Mila both said. I became the CEO of my own healthcare. Yeah, and it made a huge difference for me, and with allowing me to just be able to have conversations with my providers and to suggest to them some of the things that I'm interested in, inquiring about research that was being done and clinical trials that are being performed right now. But it really just changed the game in terms of being able to communicate.
So I love that. So you kind of talked about how or we talked about the importance of research and the importance of educating yourself, and ultimately how that led you to become more vocal and feel more comfortable asserting yourself and answering various questions. And so that's definitely something that we as patients can keep in mind, so that we do feel more empowered in those settings. Quisha, as our representative for the providers, you mentioned you're surprised that some of your patients with diabetes have never received the basic foundational services typical for those who are newly diagnosed. So what can providers do to actually ensure they're giving objective and quality care to their BIPOC patients?
So first of all, I always like to say 3 words: refer everyone, period. You got a newly diagnosed, don't assume that Mr. or Mrs. Jones is not going to go, she's a single mother with too many kids, she doesn't have time. Refer everyone, period. It's that simple. Refer them to a dietitian or nutritionist, refer them to a community education program, refer them, period. Secondly, full disclosure is needed of all diabetes treatment options that are available to them. Don't make assumptions on what you think was going to be the best. Okay, they need insulin, let's just give them the vial and the syringe. They'll be okay with that. Don't make assumptions on what you think they can afford. Of course, they're going to be able to get whatever their insurance can provide, but you really, really do need to provide full disclosure of all the latest diabetes treatment devices, medications, et cetera, because we want our patients to really be empowered to be in on that decision-making processes. We've got a lot of research and a lot of studies that show when patients are involved in their care, then they're more successful and they're have better patient outcomes. So full disclosure. And then I think the third thing is frequent follow-up and check-in. And so, you'll often hear it said, follow-up as needed. No, don't follow up as needed. Follow-up is follow-up is needed. And so doing those things, referring everyone, full disclosure of all treatment options, and follow up frequently and often, I think will help providers provide that quality treatment for BIPOC patients.
So those are like 3 for everyone, period. Full disclosure, frequent follow-up is needed. I love that. Before opening the floor up for our Q&A, I wanted to turn it back over to our advocates living with diabetes. So Kyle and Mila, whoever wants to start can start. What impact do you hope your work and this conversation will have on those in attendance today? And is there one specific takeaway that you hope they leave with?
I'll go first. I hope the takeaway is just for personal responsibility as far as one's management is concerned. And I know that's a big ask, because it's not easy when you have your life going on and then your life is interrupted with this diagnosis, and which requires all of this intel that is just not readily available if you're not aware that it's out there. So I think just arming ourselves with the information that's available, learning about the diabetic resources that's available, about the various treatment options like Quisha pointed out, various management options, even little tricks we can do at home, like pre-bolusing and corrections following meals and adjusting basal rates, if you're experiencing hypo or hyperglycemia. These are tricks that we all can just incorporate into our management that really, really helps to sort of correct a lot of the issues that we experience as people living with type 1 diabetes. And for some reason, the people, especially people of color that I talk to, we're not accessing this information, and it is available. The reason why we're not accessing it, I'm not really sure. Maybe it's because we're not really seeing ourselves in a lot of, especially on social media, we're not really seeing ourselves with a lot of like the advertisements and with a lot of the organizations that are available that are sort of distributing this information. But we just have to be more diligent about like trying to find this information out and figure out ways to better care for ourselves.
I think for me, my takeaways would be two things. I think one, if you're a provider or a device manufacturer or a part of the diabetes community as a whole and giving us resources and tools to live and manage better a life with diabetes, please just be cognizant that people of color are speaking up and we want to have our voices heard. And it's not enough just to listen and say like, okay, we're gonna do the same thing. Listen and actually take action to make sure that our voices are incorporated in what you do and that you're hearing what we're saying. And then I think for people of color who are advocates and who are living with diabetes, it may seem frustrating to feel like you're not represented or you're not heard, but that's exactly why you keep speaking up and you keep sharing your stories and you keep just overwhelmingly letting people know that you're there so that your voice can never be ignored, and that people will finally listen to you and finally hear what you have to say. So I think for everyone listening, maybe that covers everyone, but it's those two things for me. It's that, you know, those stories are incredibly important and they do drive change and they do drive the way that people of color can be perceived in the healthcare system, but it also takes the other side, the providers, the manufacturers, device companies, et cetera, everyone else to make sure that those stories are being listened to and heard.
So just to sum that all up, we have from Kyle, the importance of personal responsibility for patients as far as management is concerned and really taking that education into our own hands. And then we have from Mila, providers and manufacturers and other companies need to be mindful that people of color are speaking and they want to be heard and they want to be listened to and responded to. So that was wonderful. I want to take a moment just to say thank you to all of our awesome panelists. I feel like so many gems were dropped during this conversation. The Q&A box is like lighting up. So without further ado, I'm going to turn it over to some of the questions that we had from our audience, with those that had the highest votes. So Quisha, you and Casey created a powerful summit this year focused on people of color with diabetes. How has the community and industry responded? Will there be another?
Well, of course there will be another. That was the first annual. Yes, there will be another. Thank you for posing the question. We want to be a lot more diverse. So for those of you that were able to watch any of the sessions, there were a lot of Black people and there were a few brown people, but we want to include diverse people of all shades. And when we talk about diversity, we mean diversity in every sense of the word. So going forward in 2021, we've got some special populations that we want to focus on. Men is one of those populations. So Kyle, maybe I'll get with you and we can talk about how we can help in that regard too. We want to talk about an elderly population as well. But yeah, the industry's responded very positively, I'll be honest. There's a lot of organizations that we've met with and talked with over the last few months that I feel are just trying to check off the diversity box. And so we're making sure that we go ahead and validate those individuals and organizations early so we could find those organizations that have a vested interest in our mission and they have similar goals so that we can work together as well. One of the things that Casey and I are extremely passionate about, of course, is diabetes education. So if you don't know, my co-founder, Casey Creel, is a master's student now, getting her master's in diabetes care and education. And from a healthcare provider standpoint, that's extremely important for us as well. So using telemedicine, telehealth modalities, as we've talked about earlier today, we do want to bring that access to diabetes self-management support to people virtually. And so that's going to be one of our biggest focus going into 2021. But yes, it's been very positive from the diabetes online community and from organizations that have honestly admitted that they have not done the best and want to do better. We're just in the stage now where we're making sure that it's not just people talking the talk, that they're actually ready to walk the walk.
I hear that. Not just talking the talk, but walking the walk as well. That is awesome. So this is to the entire panel, and whoever wants to respond can feel free to do so. Can you all also share tips on how to be the best possible ally as a non-BIPOC person? How can we best help? I feel like there were some gems deposited in the conversation that can answer to this. I see Quisha wants to respond. Anyone else who wants to respond to? Joyce? All right, so Quisha again, and then Joyce.
Actually, go ahead, Joyce. Mine may be a little bit long. I want to read something. It's like 3 paragraphs. Well, it's not that long, but I want to read something. Go ahead, Joyce. I've got to share this.
Alrighty. So basically, I would say what I mentioned is to look within yourself, and it sounds like it's so general, but really, hey, how old are you? What's your nationality? What are your morals and values? How do you feel about other people who don't have the same morals and values? And sit with that for a moment and see if that really is your bias coming out when you are meeting somebody. Like, for example, I'm going to put myself out there. Okay. So I thought that, maybe more Black African-American people don't really like to eat vegetables as much. Okay, this is a bias that I have. Then I went to this vegan restaurant and it was Black owned and there were so many Black people there. And I was like, oh my gosh, you're so wrong. Like, there's a community of Black vegans in Dallas that are very strong into health and wellness. And I love that. And that is one of the tips on how to be an ally or address your stereotype is to put yourself in a position where you see people that are, let's say, just Black in general, that you don't think would be like a yoga teacher. Take a yoga class with a Black yoga teacher. See if there's any like real difference and see how you feel, if you really still feel like zenned out by the end of it or you got your workout. Try some of the food that's like vegan from Black owned vegan restaurant. I feel like we need to do more work in putting ourselves in positions where we're not comfortable because we're not used to seeing these two associations because we did not grow up that way. So those are one of my tips, and that's really called about being individualizing a person, not just by what your association is with what you think Black people should be, or like Latinx folks, or even Asians.
Love yourself out there, Joyce, to serve as a teachable example. Quisha, maybe you can give me 2 paragraphs instead of 3.
No, I mean 3 sentences. I have to read this. I came across this on LinkedIn this morning, and I'm speaking again from the healthcare provider point of view, but there are 12 BIPOC first-year medical students that are coming together to create a new Hippocratic Oath. And I have to read why they came up with this in just 3 lines from the new Hippocratic Oath, and then I'll paste the link here in the chat. But the new oath asks physicians to eliminate their personal biases, combat disinformation, to improve health literacy, and be an ally to minorities and other underserved groups in society. So I'm going to read 3 lines. I will care for my patients' holistic well-being, not solely their pathology. With empathy, compassion, and humility, I will prioritize understanding each patient's narrative, background, and experiences while protecting privacy and autonomy. I will champion diversity in both medicine and society and promote an inclusive environment by respecting the perspectives of others and relentlessly seeking to identify and eliminate my personal biases. I will be an ally to those of low socioeconomic status, the BIPOC community, the LGBTQIA+ community, women, differently abled individuals, and other underserved groups in order to dismantle the systemic racism and prejudice that medical professionals and society have perpetuated. I'm gonna paste this into the chat box. Reading it gives me chills. If you wanna know how you can make a difference, read that, let it sizzle in your spirit, and try to be a better person every single day. Thank you.
Thank you for sharing. That was powerful. I know Amy is going to just to wrap it all up, but I wanted to give Kyle an opportunity to respond to some of the questions that popped up in the Q&A. So maybe if you could just give us one response to all three questions that you received. One was about creating a foundation focused on access to diabetes technology. What are some of the challenges you face having a nonprofit? So yeah, there are three different questions. I just wanted to give Kyle the opportunity to share.
Okay. One of the challenges that I have experienced in establishing my foundation is financing, of course. And a lot of organizations founded by people of color run into this as an issue. And also, I found connecting with a lot of the manufacturers and pharmaceutical companies to be really difficult as well. But what I have found has helped me is aligning myself with other organizations which have really made making those connections a lot smoother. And it's really helped me, especially I have a fundraising event coming up on next weekend entitled From Broadway with Love. So the stream is free. Anyone that's watching, please RSVP. It's going to be a great show. But yeah, making those connections were really difficult. And it wasn't until I began aligning myself with other organizations that some of those doors began opening, which is really great. What's another one of the questions? Can I share some negative and positive experience managing diabetes as an actor? Again, like I mentioned, that first year of having diabetes, I was working with The Lion King, and it's a very active show. It requires like a lot of energy exerted on stage. And there are times when I would leave work. I would go into work with my glucose at around 300 because I knew by the end of the show, I would be crashing. And sometimes that would go down to like the low 20s. Luckily, I've never passed out or never fainted or anything, but it was really rough. And learning how to manage my glucose and really incorporating the technology and learning a lot of the bells and whistles that I mentioned before, little simple tricks have helped me so much. To now, the difference now, I can go to work, my glucose is within range, let's say 120 to 150. By the end of work, I'm usually like around 80. I have my snacks with me, but it's all manageable. But it took me about 1.5 years to figure out how to do that safely. Is there another question?
Hi guys, I'm hopping on. This has been amazing. Thank you so much. Plug is to make sure people heard Kyle's about Kyle's event that's actually happening for World Diabetes Day, right? November 14th from Broadway with Love. We actually posted in our World Diabetes Day recent article at DiabetesMine the details about it, but they can go to your Facebook page, right, and sign up if they want to stream and be part of that amazing production that Kyle's putting on. So just want to make sure I got that in there. And thank you guys all for putting yourselves out there. This has been an amazing conversation. I hope it won't be the end of the conversation, but rather the beginning. Quisha, thank you for sharing that manifesto. I'd love to learn more about it and how we can get it out there more broadly. I think people need some kind of a creed to live by to understand how to approach this and be sensitive. So thank you so much for sharing that. Ariel, is there any last words you wanted to say as we wrap up this session?
No, I mean, thank you again to all of our panelists. I think people hopefully have walked away and will walk away with a lot of learnings. I know that I sure did, and I certainly feel inspired to continue the work. So I'm hoping that other people feel the same.
Awesome. Well, thank you all for being here. Again, thank you so much for sharing your perspectives and for helping us to put this whole program together, including the survey data, which, by the way, all of this will be posted on our dData Exchange site following the event. So I think we're going to slowly take you all off stage. And honestly, we're going to continue in this vein because building on what we just heard, of course, it's imperative that diabetes research also be more inclusive going forward. So to talk about making that a reality, about how can we actually be more inclusive in these diabetes research studies, we actually have with us today Bryn Marks. Bryn is a pediatric endocrinologist at Children's National Hospital in Washington, D.C., and assistant professor of pediatrics. She lives with type 1 diabetes herself, which drove her toward a master's in health science professions education and her research interest on developing innovative educational tools for clinicians and patients, specifically on diabetes technology. So she is currently working proactively on helping to build out best practices for the clear need to expand diversity in diabetes research. So let's welcome Bryn now. All right, thank you, Bryn, for that work, and thank you for the presentation. We're going to be bringing Bryn up to answer some questions here in a moment, I hope. Let's see, go ahead and post any questions you may have in the Q&A. Hi, Bryn.
Hey, Amy, thanks so much for having me, and especially for the chance to follow that wonderful panel. It was a really nice framework to put this current discussion around.
For sure, for sure. And I think it's a really important follow-on, obviously, that especially areas like research that, as you said, have sort of had, they've been kind of institutionalized and had sort of preconceived notions of who should be participating, and it's such a small pool. So love to see this work being done. I actually wanted to ask, is there any type of coordination at this point between centers, either regionally or nationally, to start attacking these issues? I mean, clearly this has been a decades-long problem, kind of a lockout of people who, you know, of a more diverse population. So is there anything kind of coordination of a program to combat that now?
There is. So the Type 1 Diabetes Exchange is putting a lot of effort into it. Recently, they've transitioned towards more of a focus on quality improvement. And with that, there have been some really interesting studies looking at the impact of race and ethnicity on diabetes outcomes. I'd encourage everyone to take a look at the work from Dr. Ebikozian. They've had several articles published that really highlight the disparities. And I think a lot of places right now are really focused on understanding the disparities and better quantifying and qualifying them so that we can then develop the targeted approaches to begin to combat it.
Yeah, and I know one of the questions I asked you when we initially connected about this was just how to go about it. I mean, I know that in my world, the patient advocacy world, we had this sort of small group of people who were sort of the old guard DOCers, and it wasn't very diverse. And it's, you know, years later, still not that diverse. It's getting much better, but it was difficult to sort of find, you know, make inroads because when you've traveled in certain circles, obviously, you know, you continue to sort of meet the same people, you know, white people meet white people, you know, professionals meet professionals. So what are some of the ways that you are reaching out to actually find these more diverse patient populations?
So we have a pretty diverse population in our clinic here at Children's National. And what I've been doing is really going through the providers. So as soon as I mentioned this study to several of my colleagues, they instantly had patients whose names came to mind that they would really like to include. And I think for me, that's been really beneficial because when a provider whom that patient has a trust and relationship with suggests doing a study like this, I think there's a greater likelihood that they'll participate. The other things that we're thinking about are really just making it more accessible. So we're planning to do a lot of this study remotely so that we don't inconvenience people having to take 2 hours worth of buses across the city to come to clinic. So focusing on things like time and range rather than A1C really allows for that remote capability.
Yeah, I think that's really important. I mean, some people say, who have done a lot of studies, say, oh, they love doing it because they get sort of, you know, this free kind of intense care, and they maybe get free, devices or whatnot, but it's also time consuming. And so I think it's also important to make sure that, number one, people know that there's benefits to it, but also maybe be compensated for their time if necessary, right? So I assume that's something you're working on. Let me see what we have going on here. So one question that just came in, what sorts of guidance does or should the FDA provide on including more diverse samples in pivotal trials? Love that question.
That is a great one. And to the best of my knowledge, apart from what I'd mentioned about race and ethnicity and how to classify that, there's not guidance from the FDA about how best to include representative populations in research. What is interesting is when you go for funding through the National Institutes of Health, they will ask you, when you're thinking about the sample that you're going to recruit, how many people from different race, ethnicities, genders do you plan to recruit? And yet, if you're not reading those recruitment strategies, there's really not much to police that, to make sure that you're following those suggestions. So it's something that's really on the clinician and on the researcher to make sure that they're handling that on their own.
Thank you. Well, we actually, tomorrow we have one of our featured speakers is someone very high up in FDA in the diabetes side, so we can ask her that question as well, because it definitely seems like something they need to address. And this other question that just came in, also something I was going to ask you, because I was thinking about how, at least where I live in Silicon Valley, all the corporations are now forcing or requiring that their employees do implicit bias training, et cetera. So the question here is, how have professional organizations started focusing on the issues of implicit bias among providers and the effect that that has? Are they getting training? Is it, how are they learning about it?
So I will say that a lot of the hospital institutions are sort of promoting these opportunities. We at Children's National have certainly had many chances to participate in these sorts of trainings recently. I've also seen some interesting research out of Stanford, specifically focusing on implicit bias as it pertains to diabetes care. And then even some of the organizations, I was just recently at the ISPAD meeting, and they had a wonderful session addressing implicit bias. So I think it's being combated from multiple different angles.
Starting to get picked up. Okay, great. So let's do one more question here. One entrepreneur here asks, how can digital health companies with membership bases support or provide awareness of these studies? So yeah, if you're a company that has some kind of a digital tool and you want to basically be part of the solution here, what can you do?
That's a great question. I'm thinking about it from the research angle, not from a company perspective here.
Can they help funnel people to opportunities to be involved in studies?
What I think is interesting is really, again, connecting with providers who know their patients well and who already have a relationship. I would think that reaching out to clinics and hospitals might offer a nice access to a diverse patient population.
Yeah, basically they're saying they want to help promote the study and aid with recruitment if possible. Yeah. Okay, we're getting tight on time, so I'm going to let you go, but I did see that there were some people in the chat saying, hey, there are other researchers who are on today who might want to connect on this topic, so I really hope you guys will reach out to Bryn. She'll be here on the platform a little longer, and we've got all of her information. So really hoping to make connections for the greater good. That would be fantastic. Thank you, Bryn.
Thanks, Amy.
Okay, so I wanted to extend a huge thank you to everyone for joining us today, our wonderful speakers, sponsors, advisors, and all of you from the patient community, industry, clinical, regulatory, and sides and beyond. It really means a ton to be able to help convene all of you, even in these troubled times. One more big shout out, of course, to our gold sponsor, Dexcom, for their commitment to this community. They're making today and tomorrow possible, and more importantly, they're doing incredible work to improve life with diabetes. And likewise, our silver sponsors, Lilly Diabetes, Omnipod, OneDrop, and Sanofi, are a vital part of the diabetes care landscape, and we can't thank them enough for their support. And of course, our bronze sponsors as well. Big appreciation to Bigfoot Biomedical, to January AI, and to GlideTech. So, whoops, going up one. So we hope you're psyched as we are about meeting here again tomorrow for our fall 2020 DiabetesMine D-Data Exchange Day, which is of course the place where we ask these pointed questions. What is the D-Data community up to? And how are these new challenges being met? So we have a very exciting lineup for you tomorrow, kicking off with looking at the future of CGM from Dexcom CEO Kevin Sayer. And then we'll hear from some key folks at the DIY community and, as mentioned, from FDA. So must not miss. And now it's mingle time. And guess what? No masks required. So we invite you to stay on the Remo program here for up to another hour if you'd like. You can chat more with those at your table, or you can move around to other tables to connect. So thank you all, and we will see you bright and early in the morning for our fall D-Data Exchange. Thank you.